Yeah. So first of all, thanks for the invitation. And this afternoon, I just wanted to really share with you the work that we do and caring for transgender and gender diverse children and youth, and really the affirmative approach, and especially in unfortunately, the issue of gender affirmation has become a really wedge issue and people come in with very strong feelings about it. But it's important that we humanize this because there are children and young people that are directly affected in families that are affected by the narratives, by the conversations, by limitations of access to care, the kinds of conversations that are occurring in society about the kind of care that gender diverse children really do need to be their healthiest and to be their best. And so, whenever I work with audiences and families and groups, I always share with them my philosophy of care and why I do what I do. I first came into this work working with young adults experiencing homelessness in the shadows of Hollywood, California. And these were young adults who had had difficult experiences in homes, in schools, in systems, and in many ways had failed to thrive. And I always liken adolescence to projectiles. On the basis of where in the basis of the headwinds and the tailwinds that they face, it will determine where and how they will land. And in truth, these were young people that we wish had landed in better places, right? And I truly feel that if you can hit rewind and if you can work with young people and their families on that other end of the projectile when they first present with questions about gender and sexual identity, and if you can build the kinds of supports internally and externally, right? If you can, the task is twofold. You have to fortify the host and you have to modify the headwinds and the tailwinds that they face if we want our young people to end up in the best places possible. And I think we will all agree that that's what we want for all our children, regardless of identification, regardless of whether they're cis or trans or spotted or striped. We all want that for all our children. And I think that's something that we can all agree on. It is my hope that by the end of our time together, you'd be able to talk about what are some of the clinical guidelines in the care of transgender and gender expansive children and youth. For me, this is not a permissive liberal agenda. This is a youth development agenda. And I want to really emphasize that this is not random, that there are guidelines, there are standards, there are skilled professionals, and that these are not easy decisions on the part of families, and these are not easy decisions on family units, but they make these decisions with expert sounding boards and professionals, that there's a process to gender affirmation. The second is to be able to describe the gender affirmative model. And lastly, is to be able to discuss some of the practical issues and considerations in the care of transgender and gender expansive children and youth. So, to begin, I'd like to begin with defining some terms. And here you see the gender unicorn, right? And this describes the many different aspects of human sexuality. First, there's sex assigned at birth, which is about the physical parts we have in between our legs. On the basis of what our parts look like, we're assigned one sex or another. But gender identity is not about your physical parts in between your legs. It's how you experience your gender psychologically in between your ears. And it's not binary. And it's because you don't fully identify as male or female, neither do we assume the opposite, right? We believe that gender identity is a spectrum. Gender expression is about how you wear your gender on the outside, in clothing and mannerisms and speech, which is very different from emotional and physical attractions. There's also a difference between gender expansive, sometimes used interchangeably with the terms gender creative or gender diverse, as opposed to transgender. Think of gender expansive as this larger population of children and youth who simply do not conform to our expectations and norms and stereotypes of what it means to be assigned one sex. They might be assigned females who happen to like male objects and male activity, or the opposite. But they may or may not have questions regarding their gender identification. They may not actually want to be seen or to be perceived as the member of the opposite or another sex. Transgender, however, refers to that subset of children and young people that do experience conflict with how they experience their gender, right? They don't just not conform to our norms and expectations. So think of transgender as an umbrella term of individuals whose experience of gender does not match their sex assigned at birth. And in this umbrella, there's trans men and trans women, but there is also young people that define themselves in differently and in non-traditional gender terms. Young people who see themselves as non-binary, as being completely in the middle of that continuum, that might define themselves as gender fluid or agender. We also really want to give comment and bring light to Two-Spirit, because in indigenous cultures, there has always been a home for gender diverse individuals. And cisgender would be the majority of us whose experience of gender aligns with their sex assigned at birth. Gender dysphoria is a DSM-5. It's a diagnostic and statistical manual diagnosis that describes the distress that young people experience when the way they're seen or when their bodies don't reflect how they experience their gender. There is a very strong body component. And the discomfort can be severe from young people who can't look at themselves, can't shower with light, that they have to be in the dark, can't look at themselves in the mirrors, to young people who otherwise have less degrees of distress. There's a social component that can vary in terms of its impact on young people, from young people who can't speak up and order their food or use their voice because we lead with our voices, to young people who have to practically live in bunkers and live their academic lives online because they can't function socially because of the magnitude of social dysphoria, to young people that can push against it. There's also a mental component to it, with being hardwired to believe that one functions, thinks, feels as a member of the opposite or another gender. So what do we know about the size of the US transgender population? First of all, our knowledge is limited because we don't routinely collect information in our probably in samples, right? We don't routinely collect information about sexual orientation or gender identity. In this one study that came out of the Williams Institute, which was based out of a Gallup poll, about 0.7% of U.S. adolescents identified as something other than cis, right, as being part of the transgender umbrella. When you take a look at school-based surveys and more recent samples, of course, the prevalence will depend on where you slice and the population that you sample. What you will see is that we see an increasing number of young people describe themselves in non-traditional gender terms, 1.8%, 2.7%. And sometimes these increasing prevalence is something that's met with, with hairs on fire. When in truth, when you hear from young people, you don't know it's a thing until you know it's a thing. And young people will tell you that as there's access to the internet, as gender diverse identities become more visible, as they become more accessible, young people come to understand their experience and give names to their experience sooner than they perhaps otherwise might have. So I really want to share with you the work that we do with young people that come to us at three distinct time points. There's not one correct gender story. There's only the individual child's gender story. And sometimes gender expansiveness or gender dysphoria might begin to really emerge in children that are pre-pubertal, because from the time we raise our kids in the sandbox, we teach them about the things that boys do and the things that girls do. And sometimes children will begin to display atypical behaviors early on. And when you will see that in the DSM-5 criteria for gender dysphoria, it reflects developmentally significant activities, choice of clothing, choice of toys, choice of playmates. But sometimes even children will tell you that they dislike their anatomy. They know mom's bodies and dad's bodies, and they know that bodies don't stay the same, and they express a clear preference for one pattern of development over another. How do we approach gender creative children? First of all, the approach has to be gender affirmative. Gender affirmative approaches recognize that gender variations are not disorders. They are diverse and they vary across cultures. When you take a look at indigenous cultures, native traditions, there is always, outside of the Judeo-Christian sort of binary model, there has always been place for gender diversity. That gender involves an interweaving of biology, development, socialization, culture, and context. And one of the things that parents will ask you when they come in is, why is my child gender diverse? And we tell parents, like in medicine, we don't have answers for many things. And the answer is oftentimes there are many factors. And I tell parents, at some point, you will have to pivot From why is my child gender diverse to what does my gender diverse child need to be their happiest, their healthiest, and their best. That gender is fluid and it is not binary. And when present, pathology oftentimes does not reside within the child, but how we as a culture react to the gender diverse and the gender creative child and the harm that we cause in doing so. Our goal when we work with gender creative children and young people is gender health, and gender health is a birthright. It's a birthright that we cis people, that we who have cis privilege live every day. And gender health is about the child's opportunity to live in the gender that feels most real and comfortable to them, with freedom from restriction, from aspersion or rejection. And the task when we work with little children is to give voice. What is your child trying to tell you now about their gender, right? And how do you support your child in a way that does not stigmatize these behaviors? And we recognize that there's a continuum of gender affirmation, ranging from the reversible, the partially reversible, to the irreversible. Reversible interventions that might apply to school age children relate to social transition, allowing your child to dress in their chosen manner, perhaps going by a different name and pronouns. And young people will assert, children will assert as far as how far they're ready to take it. I'm ready to take it to school. I'm ready to take it to church. I'm ready to take it to the playground. I'm ready to take it to camp. It's really about how you accommodate the child as they progressively assert while looking for the child that is insistent, persistent, and consistent. And distress is never good. When you, as a parent, begin to enforce gender roles and norms and you see your child respond with distress, your child is trying to tell you something, right? Now, we recognize that not every gender creative or gender diverse child will continue to express gender creativity later in life. And I tell parents, I'm not here to make your child trans. You might have a cisgender assigned female child who just happens to like male stuff, and that's perfectly okay. You might have a child that might one day have questions about their gender identity, and that's okay. You might one day have a child that might have questions about their sexual orientation, and that's okay. Affirmative approaches really emphasize that each of this is an equally positive outcome of identity development and growth, that they are no less for being one instead of the other, right? And so the guidance that we really have for families is to let your child lead you. And when I work with families, I emphasize bias. Last week, I asked my 9-year-old child, do you know what bias means? And this was a new patient and this assigned female at birth. I think I know, but I don't know how to put it to words. I go, for me, it's about when you treat children differently because of who they are and what they are. And if we can believe that cisgender children are experts at their gender, it would be bias for us to not believe that gender diverse and gender expansive children can be similarly experts at their gender, just like cis children are, right? And our guidance to parents really is to let your child lead you, right? Because we recognize that again, not every child will end up in that same place. And there's not good data as far as who does and who doesn't. And when you take a look at surveys, there was one study that's often quoted in the Netherlands. I don't want to use the language of desistance, like persistence and desistance too much, because we step into an anti-transgender rhetoric space of, oh, like they're desisters and persisters, and it's so much more complicated than that, right? But you will see that because not every child, will continue to persist, will be insistent, persistent, and consistent. We tell parents, like, let your child lead you, which doesn't mean to say, let me wait and not support my child in the meantime to see where they land. It means listen to what your child is telling you now. It may change, it may not, right? And probabilities and percentages don't help you as a parent when there's one child in front of you. 30%, 40% is meaningless because if it's your child, it's 100% for you, right? And so I really tell them, listen to your child. You will see that the guidelines around social transition have changed. The previous language says, because we know that not every socially and emotionally socially transitioned children are, you will see that in 2017, the guidance actually indicates that, yeah, there are cases where an early and complete social transition can result in a more favorable outcome. because we don't know which child that is, we see that there might be a place for connecting with experienced professionals. And so a lot of what we do with parents of young children is really normalizing, how do you support your child? How is your family responding to this? How are they navigating school? How are they think about the headwinds and the tailwinds, right? Is really doing a temperature check. Sometimes this can be a bit of a dance for parents. One parent can be a step ahead, one parent can be a step behind. How do you be a resource to both so that they can come together and support their child in what can be really transformative work? The next piece to this is really about educating families around what might be next. If your child continues to be insistent, persistent, and consistent as they enter into their pubertal years, that we then perhaps give consideration to puberty suppression if and when that time comes. Let's pause here and talk about the care of pre-pubertal children and social transition so that we're not, right? So that we're covering it in the context of development.
I was going to say, does anybody have any questions you want to drop in the chat so far?
No,
Okay.
so far, nothing.
All right.
So let's move on to what if they have gender dysphoria? What if puberty resulted in an increase in gender dysphoria? What if the family has a good understanding and the child is clear? I don't want this puberty. And puberty that is not consistent with your identity is traumatic for young people. When I work with little children, they're just happy, healthy little children before the trauma of puberty and the many cumulative hits that they oftentimes incur in society. And oftentimes, you see that around puberty and around these years is really when the dark cloud's going to begin to come in, right? So remember that what happens before puberty is your brain does not speak to your gonad, and your gonad is either an ovary or a testicle. What happens in puberty is your brain begins to produce FSH and LH as messengers in the form of pulses. Hey, time to enter into puberty. We always find out how old was mom at period? Was dad an early developer, late developer? Because you will find that families whose parents and other children develop early might tend to develop early. So what happens is once your gonads, your ovary or your testis begins to activate, you begin puberty. In assigned females at birth, so 1 is undeveloped, 5 is fully developed. In assigned females at birth, the first sign is the development of a bud behind the chest, right? So breast budding. We try to not use gender terms that might cause dysphoric youth to, right? So, and that can happen as early as age 8, and it continues to progress. Puberty blockers in assigned females are really ideally intended, the sooner the better. Right? By the time you have your first period, 1 in 4 people are in the 3rd stage, 2 out of 3 people are in the 4th stage. In assigned males at birth, the first sign of puberty when you go from 1 to 2 is testicular enlargement, when it becomes about the size of a Jordan almond. In both males and females that are assigned at birth, your gonads, when you activate about 6 to 12 months later after your adrenal glands do, wearing deodorant, smelling a little bit sweatier, smelling like the locker room. So puberty blockers are really intended, they're really best used the earlier the better. And the benefits of puberty blockers is that they can extend the space for gender exploration, right? When you think of how early pubertal changes occur, this can be a way to hit pause, because it's easier to hit pause than it is to rewind, to allow the child the opportunity to mature, to process, for their families to come around, while preventing changes which could be very difficult and which can cause a lifetime of disadvantage. Whenever we work with families, we are not permissive. We are not permissive. By the way, going back to the benefits of pubertal suppression, I will tell you, hips don't lie, right? And you will see how much easier passing and integrating can be for children that have had the benefit of puberty suppression. This is not a permissive liberal agenda. When we work with families, we present the risks and benefits, and we have very intentional and focused discussions, because we emphasize to families, these are not small decisions. Remember that that your sex steroids, estrogen and testosterone, are not only for pubertal development, they also help you soak calcium into your bones. And these are young people's peak bone laying years. Young people that are on puberty blockers may not soak up calcium into their bones the way that non-block peers do. And we don't know what this means in terms of lifetime risk for osteoporosis or osteopenia or fractures. And so we have a protocol for monitoring bone density during, encouraging calcium intake, maintaining vitamin D levels. We get very detailed family histories, finding out about cardiac rhythm abnormalities. And more, however, I list expense here because more and more we see that insurances really do cover this. Rare is the health plan that has this as an exclusion. Although to be able to avail of this, we have to submit for prior authorizations. And we also really require that young people have had the chance to work with skilled gender therapists, right? This has not come to the front of the line. I want puberty blockers. Oh, here you go, right? That's not how it works. And puberty blockers were really developed for young people who entered puberty early, precocious puberty. And they're a way to hit pause in patients with precocious puberty once they're ready to progress with puberty at around the same time as their peers. When you unpause, things proceed like you didn't pause. In this case, we use it as an opportunity to pause puberty, especially in the setting of distress. When you take a look at the research studies looking at the outcomes of puberty suppression, they consistently speak to the positive benefits of puberty blockers. And young people will describe puberty as a runaway train, as I can't deal with it. Sometimes the thought of puberty progressing could be so significant, it can really impede function for young people. And again, I tell this to patients, I tell this to families. We have one goal: to help young people be their healthiest and their best. And that might look differently than what treatment might be pursued. But we definitely recognize that puberty can take a toll on young people. In this study, which was published in 2020, it actually showed that transgender adults who had the benefit of puberty blockers had significantly lower risks of having thought of or attempted suicide compared to young people that hadn't. And this is significant for a population where 40% of whom have actually attempted suicide in the past, right? This is life-saving work, and these are life-saving interventions, and they're not small decisions. Families come to it with a lot of feelings, and it's very complex for families. And to narrowly paint it as yes you can and no you can't is not the spirit that we should be approaching this work with. Let's take a pause here before we talk about gender affirming hormone therapy.
We do have some questions here.
Yeah.
There are a couple ladies who are very concerned about bullying, both physical bullying and legal bullying. Those are huge, huge concerns for some of the folks here. Do you have anything to add? Because I know even here in Ohio, where Julie and I are, there are laws attempting, I think they're in committees right now, attempting to stop this type of work.
Yeah. So as far as physical bullying in schools, first of all, schools are for you to learn. You can't learn when you don't feel safe, right? And we know how important academic achievement is to the future life course. How you do academically is a social determinant of health that will affect the child's life forever. And so we always ask families, and stay connected with your child. Ask your child how school went today and every day, and to really be involved. We have those conversations, and we connect families with examples of gender support plans. We have children and young people who might otherwise switch to online school or switch schools as they're advanced in their social transition, so that they get to start fresh and they get to start new, right? Without the benefit of, oh yeah, this person knows me. And so it looks very differently for individuals. Are you hearing a beep?
No.
Yeah. All right. It's probably on my end. So in terms of, we have a very active parent support group here in town. It's called the Arizona Trans Youth and Parent Organization. And the president of AZ Taibo happens to be a public school teacher. And so they have been very good about accompanying parents to meetings with school districts and really how we create inclusive environments in our schools where our young people can best be their authentic selves and thrive and learn is really what that looks like. In terms of legal bullying, the support for gender diverse children has been tested as a wedge issue that can mobilize the base, just like other wedge issues have been tested. And when you take a look at the legal initiatives that are sweeping across our legislative houses across the country, they look a lot alike. They operate out of the same playbook. But you also have to recognize that for every action, there is an equal and opposite reaction. In the last years, as we've seen visibility of transgender individuals come to the forefront and support and the previous administration and accommodations in schools, this is the equal and opposite reaction, but we just have to stay on top of it. There are research studies that talk about the impact of anti-transgender bills on laws, on parents, on family units, on children, and it is not good.
Then the second question that we have is, will puberty blockers stop the shoulder broadening and development of the Adam's apple in an assigned male at birth child?
Depending on when it started. If you started before yes, it will.
Okay. And that's what we have right now.
Wonderful. So for assigned females at birth for whom chest dysphoria is so predominant and they bind and there's so much distress over chest, I'll tell you, puberty blockers sometimes can result in a little bit of regression of chest tissue. So you may see, in fact, a little bit of a rewind with puberty blockers, although sometimes when you first started, like your brain doesn't recognize, you're trying to substitute, because puberty blockers are monthly, quarterly, or injections. There's a 6-month version, there's an implant which lasts 1 year according to the FDA guidelines, but what we see can actually last as long as 2 years, is you're trying to substitute pulsatile messaging on receptors with tonic sustained messaging, right? Sometimes when the analog, when the growth hormone receptor, when the GnRH analog hit the receptor doesn't always know that it's not pulsatile, it just know it touched. So sometimes you can see a little bit of advance in puberty before things begin to regress. All right, are we good? Shall we move forward? All right, the next phase is gender affirming hormone therapy, right? Remember that puberty blockers only prevent the development and progression of male or female or masculine or feminine characteristics. They don't give you the desired secondary sexual characteristics of the other gender or another gender. And so when young people feel that, yeah, I'm ready, or I'm delayed relative to my peers, and that looks differently in different places, right? We then think about introducing gender affirming hormone therapy. And the principle with gender affirming hormone therapy is your body is really smart. For any hormone it produces, it knows how to up dial and down dial to make sure that there's just the right amount. Once the brain recognizes there's enough estrogen, it will lower LH, FSH. Not enough, it will raise it. It can't, because it can't tell the difference. With gender affirming hormone therapy, we give patients enough of the opposite hormone to confuse their brains and bodies into thinking that there's enough of what it would otherwise produce, thereby shutting down endogenous production, but then receiving the opposite from the outside. That might sound simplistic, but that is honestly how it works, right? And so there is a criteria for initiating gender affirming hormonal therapy. You do not come to the front of the line in pediatric clinics and we say, here you go. That's not how it works. Not only do you have to fulfill the criteria previously discussed of having a diagnosis of gender dysphoria, in European jurisdictions where young people typically can consent for their own healthcare and hormonal therapy, they don't usually initiate gender affirming hormone therapy until you're 16. And you carry your own insurance and socialized systems. You work with one unit, the child, the young person. Parents are removed from the equation. And at 16, they feel like, yeah, they're good, right? Here in the US, where that doesn't give you the ability to initiate gender affirming hormone therapy. We feel that allowing young people the chance to enter puberty at around the same time as their peers allows for better adjustment. If I block a male identified assigned female at birth at the age of 9 and didn't introduce testosterone until they were 16, they would look like a 10-year-old, 16-year-old. How would you like that? Right? How would you like to be the least developed, shortest kid in class? But again, we emphasize that it's not about your chronological age. It's about where you are developmentally. You can have a prepared, mature, supported, thought out, researched 14-year-old. You can have an unstable, immature, poorly thought out, unsupported, unstable 18-year-old. And we really rely on skilled gender therapists that have been their expert sounding board to say, yeah, that this child demonstrates the understanding of risks and benefits, a commitment to this, their parents are on board, the family unit is prepared to move forward. And we tell families to take as little or as much time as they need to get to that point. The World Professional Association of Transgender Health does not give guidelines on age. It just says, right, we cannot arbitrarily assign an age because we recognize that, right, that this can be difficult. So unlike puberty suppression, gender affirming hormone therapy is only partially reversible. Testosterone therapy is pretty dramatic. Your voice will deepen. By the time they get to 6 months, 1 year, they sound completely different, which can be very liberating for males, because for male identified patients, because we lead with our voice. We who have cis privilege, we don't know that. We don't live that. You will get body fat redistribution. This is, by the way, is for feminizing hormones, right? So breast growth, muscle mass, softening skin. The important thing here is really that something happens before other things, and having a good understanding of what happens when is critically important to building satisfaction and building preparedness for self-love and a positive self-concept, right? And confidence to step out and be you and do you. The things that don't change or may not be complete are hair growth. So some patients might need hair treatments, electrolysis, laser therapy. Voice, once it has deepened, does not change. So we do have a voice coaching program, but we definitely going to go through these with our patients. The irreversible aspect of treatment, should patients say, I'm ready to discontinue treatment, would be breast growth, right? Depending on how far you are, you may not completely reverse that. With testosterone therapy, you will see that there's acne, there's voice deepening. This is much more pronounced and dramatic. You lose your periods, you will build muscle mass, you will have body fat redistribution. The slope is rather steep in the first year, and then it begins to plateau. So again, making sure that young people have a good understanding of what happens when is critically important. The things that might only be partially reversible would be voice and hair, right? Once testosterone has deepened your voice, it stays deep. Hair growth as well, right? But this does not only mean to say that the standard to support the child seeking partially irreversible interventions should be higher than the child seeking fully reversible interventions. It also speaks to the diversity of gender journeys. So I have a 16-year-old young trans male who I care for, who received puberty blockers at 13 and a half. At 15 and a half, he tells me, Dr. Chulani, I'm ready to stop my testosterone. Not because I'm any less trans, but because I look like any other 15-year-old. I'd rather not do injections. I feel like I totally pass, is the language, right? I'm like, sure, if you stop your testosterone, you might lose a little bit of the muscle that you built. Some of that might fade. Your periods will come back. No, I don't want that. So we talked about ways of stopping his periods instead. How old are you? 15 and a half. Well, if one day when you're in your 20s and you feel like you look like a 15 and a half year old male and you want to restart treatment, let's have a chat. There's not one algorithm. You have to individualize gender journeys. And which is why I really sort of don't step into that detransition crack, because there are many reasons young people feel differently about treatment at different points in time. And it's not a binary, yes, I'm still trans, and no, I'm not trans any longer, right? Especially since that narrative has been so hijacked. For surgical care, the guidelines typically for genital surgery is still that you have to be 18 years of age. And however, for chest reassignment surgery, the WPATH kind of says, well, you really can't give it guidelines, right? So they make no comment on chest reassignment. And in the past, we have patients that have completed chest reassignment surgery at the ages of 15, 16. And this is where we're seeing some legal initiatives that try and restrict access to minors accessing gender affirming surgery that really mostly affects our transmasculine and our non-binary identified patients. Before, the guidelines were, first, you socially transition. After 1 year of socially transitioning, you start testosterone. After 1 year of testosterone, maybe we'll consider chest reassignment. But the journeys aren't linear. We have plenty of non-binary identified young people who don't ever want testosterone. They just want their chest gone, right? So we are seeing a lot more adaptations, and we're not as linear because we know that life is not a straight line. And we really have to listen to our individual patients and families' gender journey. Now, the literature on regret has also been co-opted. Oh yeah, they regret. The true correlates of regret, the true prevalence of regret is around 3 to 5% based on the best available literature. And they are largely a function of poor social support, late life transition, severe psychopathology, being unhappy with their appearance, and poor surgical outcomes, right? Now, when I come to this work, actually, let me pause here. Any questions about gender affirming hormone therapy before I talk about equity?
Yes. One of the moms is worried that her small child who is so small, below the 20th percentile, will remain being small because she said assigned male at birth have later growth spurts than assigned female at birth. So is that something that the hormone therapy could make happen?
So that's a little bit of a complicated question. Puberty blockers can actually change your final adult height. In assigned females at birth, they have their growth spurt so kids grow 4 to 6 centimeters a year. In assigned females at birth, you grow about double that 1 year before your period, and then your growth winds down. If you start puberty blockers for their first period and before the growth plate closes, you extend the 4 to 6. They grow longer, they end up taller, right? In assigned males at birth, the member who asked the question is correct. The growth spurt does not happen until the fourth stage of puberty, right? And so they grow 4 to 6. If you get them on puberty blockers, they skip out on their growth spurt. But estrogen, when introduced, if introduced, is a potent agent at closing the growth plate. So they end up shorter than they otherwise would have been, which can be helpful for our assigned males at birth that are female identified, whose predicted height is 5 feet 8, is 6 feet 8, 6 feet 4 inches tall, right? But I think you might have a member of your group who actually has a assigned male who is already on the short end of the growth curve. So puberty blockers can definitely modify that further. Mm-hmm. But I think I would recommend consultation with an endocrinologist if and when the time comes, right? I always say if and when, because I'm not here to seal the stories of children, right? I'm not here to seal you and your family's story and your journey. We keep it open. And so I would say consultation, but if and when. But I also emphasize to children that there's many ways to be masculine and there's many ways to be feminine. They come in all shapes and sizes, which is important when I work with my transmasculine patients and they're like 5 feet 3, 5 feet 4. I'm like, be careful, I'm 5 feet 6. But also go to Asia.
And I'm 6 feet tall.
Go to Asia, where I was born and raised. There are entire countries of 5 feet tall men.
Yeah.
because sometimes as much as young people defy the binary, they buy into the binary. Mm-hmm. And I always tell them, if you only have one version of masculinity and femininity in your head, you will be hard on yourself. Mm-hmm. You will see yourself as either that or not that, and that will undermine your confidence in stepping out, right?
Mhm.
And I say confidence is not only how other people see us, it's how we see ourselves.
Accurate.
This
Okay.
is this work is really how we prepare young people to love themselves.
That's wonderful. So I have two more. One was a question on, are there long-term ramifications from being on hormone therapy?
Yes. So once again, we have very detailed conversations about risks and benefits, right? So the long-term complications, first of all, we have to recognize that there has been a historical exclusion of a transgender health agenda in research, which limits our knowledge because of bias and structural bias, right? We've excluded them and we've excluded their needs, but that's changing. The things that stand out, first of all, when parents come in, what's the risk? I always say, separate from general risks, it's the risk your child brings to the table based on their personal and their family history, right? We have families with clotting mutations and strokes and sickle cell disease. It has to be individualized. Separate from individual and familial risks, the biggest risks with testosterone therapy really are the potential for changes to your cholesterol tests and your diabetes risk. The same is true for feminizing hormone therapy because your body fat percentage will increase. Females have different body compositions. And with that increase in body fat percentage, you can see shifts in some lipid levels and also in diabetes risk.
Mhm.
So we always emphasize the importance of making healthy lifestyle choices and building healthy habits because these are things that can prevent and mitigate some of the concerns that come with treatment.
And then another question was, are there any studies on how the increasingly young age of puberty is impacting the health of children in general? In our gender role binary society, earlier onset puberty seems to be a traumatic event.
You know, when you take a look at early developers, especially for assigned females at birth,
Mhm.
the preponderance of the literature will talk about it being a difficult experience. Like all of a sudden you get picked on and you get catcalled and you get, think of how we treat women in society,
Mhm.
right? And that it's almost like the spotlight gets gets put on them before they're ready. And but especially if they, and that's for cis kids. This is the
Mhm.
literature on cis kids, right?
Yep.
In general, with males that are early developers, you don't so much see that because there's oftentimes an advantage to being a little bit of an early developer with males in terms of school, in terms of sports, in terms of athletic ability. And of course, I recognize, I always listen to myself. I'm playing into binary stereotypes, but we're talking about cis kids, right? But yes, there is some literature about that it's not always easy. But I'd also like to think that, there's some things you can't help. If it's normal physiologic puberty, the best we can do as parents is stay connected with our kids so that we know how they're responding to it, right?
Mhm.
And also really guide our kids around what to expect, what not to expect. And puberty happens to all of us and the best of us.
That's accurate. Okay, and I was 10.
Right.
So I can relate. All right, that's what we have for now.
All right. So first of all, I come to this from the perspective of an advocate and an activist, and we recognize that there's tremendous disparities affecting transgender people, and we have to recognize that there is stigma. Stigma is that undesired differentness, right? It is, it is the right and stigma operates at different levels. Stigma is internalized. And internalized stigma is when young people take in negative messages about what it means to be who they are. I was working with a transgender female who was 17, I believe, at that time, and I asked her, "What do you want to be when you grow up?" "I want to be a school teacher, but I don't think I can be," because which parent could really trust their child with a transgender school teacher? Internalized stigma is damaging because young people will live up or live down to our expectations of them and their expectations of themselves. And my job is to help young people break down internalized stigma so that they can be their best. Stigma is personally mediated. Personally mediated stigma is prejudice, discrimination, bias. We see it in rates of violence that are directed at transgender women of color. We see this in bullying in schools. We work with our young children and our parents and our families to create safe environments for our children. It's our responsibility as adults to secure for our children the best environments for them to thrive. That is not their responsibility. It's our responsibility. It's our duty. Anything less than is a dereliction of duty and an abrogation of responsibility. But stigma is also structural and institutionalized. When you take a look at the disparities affecting transgender communities, they are rooted in structural stigma. We see this playing out in laws, right? And so how do we promote equity for young people? I always say from the inside out and from micro to macro. From the inside out, beginning with the internal, because the most potent weapon of the oppressor is the mind of the oppressed. Helping young people come to see themselves for the promise and the potential that they carry and that lives within each of them. Connecting them with supports and services and resources, teaching them to engage in good self-care and to become empowered and to themselves be involved in creating the conditions that affect them in day-to-day through activism and empowerment is what I call from the inside out. The approach for us in healthcare, it is affirmative, it is culturally humble, it is trauma responsive, it is strength-based, because we know that when young people are provided the supports and resources that they need to be their healthiest and their best, they can and will thrive. In my clinic, when young people come in, we have a trans Christmas tree, we give them pronouns, we give them affirmations with these little rocks that this one says, "You are courageous." And we really go as far as building visibility with our staff through pride shirts and communicate safety, right? That they can expect different from us, especially given the kinds of experiences they may have had in other healthcare settings. In our setting, we avoid cisgender and cishet assumptions. We train our staff. We have non-discrimination policies. We honor names and pronouns. And we really strive to build gender inclusivity in our process. That for me is the micro level work. But just as liberation proceeds from the inside out, it also proceeds from micro to macro, right? As important as it is to meet patients and families at the micro level, at the service delivery level, even now, these levels, by the way, are not mutually exclusive. They are self-reinforcing. Advancements in one reinforce the other. Equally important is meso-level change and how we transform our organizations and our institutions to be more inclusive and to create spaces for gender diverse young people. But we also have to recognize the tremendous impact of macro in structures, in large systems, in public policy, especially now. And this really is a call for us to be mindful of the choices that we make. And may the choices that we make in ballot boxes reflect our commitment to all children, to secure for themselves the best possible environments for them to thrive, and that honors justice, that honors human dignity, that honors rights, and that really recognizes the social capital and the human capital that resides within every individual, cisgender or not. So when we work with families, we really just chit chat. Let me know about your story. Where's your family? You have to view gender diversity in the context of faith, family, culture, tradition. How are you managing this, right? Because we have to support parents to better support their children. We talk to children about what's it like being you? How does gender dysphoria impact your function? What are your goals? How far have you taken it? What are some of the barriers that you are dealing with? Transition is social, transition is medical, transition is legal, transition is surgical. Where are you in your process, and how can we connect you with the resources that you need to navigate the many aspects of transition? How we connect you with resources and community, because community can be powerful, and how we empower and engage you. And I would like to end with this. I will send this to Julie. I have references and I have websites and resources. All right, let's stop here. Questions?
Yeah,
I have a heart.
Say, if you guys do have any, I know you guys already asked some pretty great questions. So if you have anything else that you would like to ask, we have like perfect timing. I think Dr. Chulani knew our timing, so I believe he was trying to accommodate us on that. But if you guys do have any other questions, I'll
There is one here. What other things besides voting can we do to advocate for trans kids?
So, first of all, advocacy, there are many different levels of advocacy, right? Advocacy is at the individual level, being a good neighbor, being a good parent, reflecting inclusivity in your own language and your interactions, right? I think sometimes we only think of advocacy as policy, but I think there are many ways we can be advocates in the many spheres of that we interact with and where we operate, right? Like in my case, I'm sorry, I was just going to say, in my case, I'm a clinician. In my role as a clinician, I operate at the micro level, but I also operate at the macro level. When we had some hateful laws coming down the pike, I was at the legislature trying to keep bad stuff from happening. But you might find yourself as a member of an organization, as a leader in an institution. You might begin with what's most proximate to you. As an employee in your workplace, as a parent in your family, as a parent in your parent teacher association, begin with what's closest to you.
Someone in the chat said, adding your pronouns, to your signature and all. And that's something that I really sat here and thought a lot about as you were speaking tonight, because I was in something else and they asked me to do that. And I thought, okay, why? But now I get it, because, I didn't understand it before. And Gen X, early Gen X. So here I am.
Totally.
But there are lots of thank yous in the chat. Thank you for everything that you do. Thank you for tonight. Because it has opened up a lot of folks' eyes, it seems. And then they ask, is trans health being taught yet in medical, nursing school, etc.?
It's definitely making its way in medical school, and you will now see like abbreviated fellowship training programs. And I mentor medical students, I mentor residents. So it's definitely happening. Now, pronouns, by the way, are a great way because you normalize diversity, right? You make it a thing. And I think that's such a great way to normalize it.
What do we say to folks who say kids are only questioning or wanting to transition because it's a fad that their peers are influencing?
I know, right? I tell them, yes, there could be that, but at the end of the day, don't we also seek our own kind? Right?
Well, I look at it too.
We seek our own kind.
I look at it too as I saw something the other day online about being left-handed. Probably about 10 years before I went to school versus when I came into school, and then after, how many folks are left-handed now versus when they used to try to change you.
Yeah, totally.
I'm left-handed, Julie. I did not know that.
Yeah,
I am left-handed too.
Oh my God, the Julies have something else going on here. The only thing I was just going to combine a couple. There was a couple of questions I just wanted to combine. It was kind of like, how do we best support the children in our life, especially like for educators in the classroom. And like, I think it's generally like, how do we best support, and then how do we educate parents who maybe are not as informed or have a lot of misperceptions or misinformation around this?
I know, right? And I really feel for educators. Not only do we have the issue of unsafe schools and school shootings because we refuse to do the right thing, that not only do we not reflect our commitment to the education of our children in how we compensate our educators. Now we are seeing initiatives that want to tie their hands from being the supports and resources that LGBT kids need, that they have to out children. How is that right for a trusted adult, right? And again, like I really feel for educators. I say just keep on doing what you can. Keep on pushing. When where there aren't restrictions, be that caring adult, because it only takes one. I was working with this one child once, by the way, and this child had everything going wrong for him, that was rejected, was neglected, was in the child welfare system, and yet he was doing well. He was in college. I'm like, what made a difference for you? And he said, my middle school teacher. You can be that, right? You can be that where your hands are not tied and the ways that your hands are not tied, where there are initiatives that try to tie your hands, don't let it be tied, right? Just keep on doing what you're doing. But at the same time, guys, we have to recognize the importance of self-care, right? Audre Lorde, in her words, right? Self-care is not self-care is not an act of self-indulgence. It's a restorative necessity for us to keep on giving, for us to keep on supporting, for us to keep on advocating. We can only do so to the extent that we have filled our cups, and we keep our cups full to the extent that we can. So take good care of yourself, especially around hateful times, but because that way you pace yourself for the work.
Well, that's a great thing to end on, because I feel like we could go all night with questions on this topic, and we really truly appreciate your presentation. I think a lot of people got informed on something they really truly didn't understand, feel better prepared to talk to other people about it. So I really appreciate your time, Dr. Chulani. Thank you so much.
Yeah, of course.
We're all about self-care here at Red, Wine, and Blue. We talk about it a lot. One of our favorite quotes was from Connie Schultz, who's a columnist for USA Today and an Ohio icon here for us. And she always talks about holding the note for other people, like a choir. People have to take breaks, but other people will hold the note and go on, take your breaks, self-care. So anyways, I want to thank everybody for coming. Thank you again to Dr. Chulani, and everybody have a really great night. Hopefully we'll see you tomorrow night at our Troublemaker Turnout training, or Thursday at the Sex Ed presentation. Everybody have a really great night.
All right. Bye, guys.
Thank you.